Hello, everyone, and welcome to tonight's TOGA webinar, Thoracic Cancer Highlights from the 2026 Annual Meeting. For those who don't know me, my name is Maggie Moore, and I'm a medical oncologist at the Alfred Hospital. And tonight I'm joined by three speakers, Professor Ken O'Byrne, Dr. Ben Kong, and Associate Professor Malinda Itchins. You'll notice from our panel tonight that we do lack a bit of diversity. We usually like to have different thoracic oncology specialties represented at these meetings. Tonight we're 100% medical oncologists, but as we move through the data tonight, you'll see that really this year's ASCO was very focused on systemic therapies and really skewed towards late-stage disease. So it made sense to have medical oncologists speaking. Before we start, I would like to do an acknowledgement to country. So the Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the lands across Australia and pays respect to elders past, present and future. TOGA also acknowledges Maori as Tanata Whanui of Aotearoa, New Zealand, and as treaty partners with the Crown, as agreed in Te Tiriti o Waitangi. Before we get started, we'd also like to thank Pfizer, without whose support we wouldn't be able to be putting on this webinar tonight. Just a reminder for those who are new to the TOGA family of TOGA's vision and mission. The vision is to eliminate thoracic cancers as a source of death, disability and suffering, with a mission to prevent, treat and cure thoracic cancers through research, clinical trials, education and advocacy. And for anyone who's interested in becoming a member, which is open to anyone interested in thoracic cancers, you can scan the QR code here. So tonight we have three sessions. First, we'll have Professor Ken O'Byrne speaking on the data presented in immunotherapy, small cell lung cancer and beyond. And then we'll have Dr. Ben Kong talking about advances in targeted therapies before Malinda finishes up with the poster pics which caught her eye at ASCO. And what we're going to do tonight is, rather than have a Q&A at the end of every session, we're going to save up all of the questions to the end and then have a full panel discussion and question and answer. But you're able to ask questions through the live Q&A function on the right-hand side of your screen throughout tonight's session, and then we'll address them all at the end. So I'll start by introducing Professor Ken O'Byrne. So Ken is known to most of us. He's a consultant and professor in medical oncology at Princess Alexandra Hospital and the Queensland University of Technology section of the Translational Research Institute. He has conducted translational bench to bedside and back again research over the past 25 years with a focus on solid tumours, particularly thoracic malignancies. Ken was the founder of the British Thoracic Oncology Group, a founding member of the European Thoracic Oncology Platform, and has held committee positions with the International Association for the Study of Lung Cancer. I'll hand over to you, Ken.
ASCO this year was, as usual, full of remarkable advances in the care of patients with malignant disease. In lung cancer, we saw some really interesting presentations. I can't remember when lung cancer had the most plenary sessions before ASCO, but this was what happened this year. Two of the 6 plenary sessions were on lung cancer, and they'll both be covered tonight. So I'm going to focus on some of the areas that really caught my eye and some of the advances I think are going to be very important in terms of care of our patients. So first of all is VEGF as a targeted therapy. As everybody's aware, bevacizumab was established quite early in the 90s as being a potential treatment for adenocarcinoma of the lung and non-squamous non-small cell lung cancer. And then it kind of faded a bit into the background, raising its head every now and then. But we're beginning to see something very interesting with VEGF targeted therapies emerging at the present time. So this is the resurrection of VEGF targeted therapy in lung cancer. Now, just to remind you what VEGF does in terms of its relationship to the immune response, VEGF is responsible for downregulating the pro-immune response to chemotherapy, to tumors, and also for upregulating the resistance pathways, for example, through Tregs, activation of Treg cells, tumor-associated macrophages, myelodysplastic cells. So it's an antagonist for the immune response, and that, as we all know, in wound healing, VEGF plays a crucial role in wound healing. But we know in wound healing also that the cell-mediated immune response is downregulated. So targeting VEGF has really been looked at as a kind of a key way to enhancing treatment that we have. So we've had anti-VEGF monoclonal antibodies and various TKIs incorporating targeting VEGF receptors. Again, these have been effective to some extent in the treatment of non-small cell lung cancer and other solid tumours. There's been attempts to combine these with immune checkpoint inhibitors to see if we can enhance survival. To date, predominantly progression-free survival has been improved. It's been hard to get overall survival benefits. And there's some evidence that perhaps using VEGF targeted therapies in cell therapy itself might enhance the activity of the cell therapies. So what is its role so far in squamous cell and non-small cell lung cancer? Well, the first study published in 2004 demonstrated, in fact, a high risk of bleeding from bevacizumab, particularly if there were solid tumours centrally based with cavities and if there was invasion of blood vessels. And so life-threatening pulmonary hemorrhage really cast a cloud over VEGF targeting in the early days. But in 2006, as was mentioned earlier, bevacizumab was approved for the use in non-squamous non-small cell lung cancer in combination with paclitaxel and carboplatin. It wasn't until 2014 that ramucirumab came through and is the first and only VEGF inhibitor found safe and effective with docetaxel in the second-line setting. There has, however, been a recent move forward with bispecific antibodies. I think this is a really exciting and very interesting area. So the trial of ivonescimab was presented previously at ESMO, looking at the combination of VEGF and PD-L1 in a bispecific antibody. The key inclusion criteria were pathology confirmed squamous non-small cell lung cancer, stage 3B to 4 disease, no EGFR mutation, ALK, no other prior systemic therapy, and a good performance status. And one of the inclusion criteria, which is important to mention, we'll discuss again later, is that the age range was up to 75. So patients over 75 were excluded from the study. And ivonescimab was combined with carboplatin paclitaxel versus atezolizumab, which is another PD-1 targeted therapy, combined with carboplatin paclitaxel that's approved in China. And this study was conducted in China. It's a Chinese population, and maintenance therapy with either ivonescimab or the atezolizumab was continued for 24 months. Now, this data was published recently in The Lancet, showing this improvement in progression-free survival, 11.1 by over 6.9 months. And many people wondered, would this actually translate into an overall survival benefit, given what's happened previously with a lot of the VEGF targeted therapies? And what we can see in this group 2, the median progression in the patients in diagrams A and B were for patients based on PD-L1 expression. And the overall survival interim analysis, which was presented at this particular meeting in ASCO, showed really a quite remarkable separation in the curves. So by 12 months, you had 72 versus 78% survival. But by 24 months, that was now to 48 versus 64% in favor of the ivonescimab combination with chemotherapy. So this bispecific antibody targeting PD-1 and targeting VEGF-A looks to be superior than atezolizumab and chemotherapy. So this is an important proof of principle study, at least in the Chinese population. However, just looking at the data, and again, I'm going to come back to this a little bit. If you look at the greater than 65 versus the less than 65 population, you can see that there's really very little evidence of benefit in this older population compared to the younger population. And this is going to be a theme I'm going to come back to several times during this presentation. Looking at the patients that were included, it was interesting to see that many of the patients had central tumours. There was encasement of major blood vessels, you can see there in a portion of the patients. Some had cavities and some had a history of hemoptysis. So in this population, which would normally we would be anxious about giving a VEGF targeted therapy, we're seeing that they were included in the study. And what we see is that in terms of toxicities, looking at the grade 3 toxicities, we can see that many of these things were what we would expect to see for chemotherapy and an immune therapy combination. But there were some specific VEGF-related adverse events that were important. And this included grade 3, greater than equal to grade 3 hemorrhage in 2% of the population on the ivonescimab arm, which, and there was still, as you would expect, a case in the atezolizumab arm with chemotherapy, as we would see anyway in treatment of patients with non-small cell lung cancer, or squamous non-small cell lung cancer. Again, though, this is a relatively low instance of significant hemorrhage for the benefit that's been gained for the patients. So the key take-homes from this particular study that were presented was that ivonescimab is a worldwide first PD-1 VEGF dual-targeted bispecific antibody that has been approved in China in 2 lung indications since 2024. It looks like it significantly improves overall survival in patients with squamous cell lung cancer, and Harmony 6 met its primary endpoint and all key and secondary endpoints, and had a manageable safety profile consistent with prior studies. A second study that was presented was the Rosetta Lung 2 study. This is a global randomized phase 2/3 trial of pumitamig, which is a PD-L1 plus VEGF-A targeted bispecific antibody, and chemotherapy in the first-line treatment of disease of non-small cell lung cancer. And you can see this is the diagram of how it works. It interferes with both VEGF, which increases vascular normalization, reduces hypoxia, helps immune cell infiltration and activation, dendritic cell differentiation, and decreased Treg or T cell and decreased regular T cell proliferation, and also blocks PD-L1, so enhancing the immune response. Now, there's some interesting preclinical data. The first is that VEGF-A, the neutralizing antibody, was demonstrated to neutralize or functionally inhibit the interaction between VEGF-A and the VEGFR2 receptor, which is important. And interestingly, pumitamig, which is obviously the bispecific, bound to VEGF-A, tends to accumulate on the cell surface and is then taken inside the tumor. And I think a tumor cell, and I think this is kind of an interesting observation because it may explain why we're seeing very interesting anti-tumor activity. VEGF-A, and people may not be aware of this, is associated with an intercrine cell signaling process that activates AKT and MAP kinase and plays a key role in cell survival inside the cell. So it's not just simply a paracrine or autocrine effect in cancer cells, but actually has this intercrine effect, particularly in stem cells. So what did the Rosetta trial do? It had non-squamous and squamous. It combined pumitamig at 2 different doses with carboplatin and pemetrexed, or carboplatin and paclitaxel, depending on the histology. And you can see again a nice distribution of patients. There were brain mets present in some patients, but a small number. And a significant number of the patients actually had PD-L1 expression less than 1%. So this is a summary of the slides, and we talk about the top left-hand side. This is the overall response rate in the non-squamous and squamous cell populations. You can see the majority of patients, indeed all of the patients, had some benefit from treatment. On the right-hand side, we can see the PD-L1 expression, and again, irrespective of PD-L1 expression, there was a high response rate. And this is kind of, the Ipi-Nivo story a little bit, where you see this benefit in PD-L1 less than 1%. We're seeing the similar thing with the PD-L1 VEGF-A targeted therapy. When we look at the ctDNA, about 60% of the patients had detectable ctDNA at baseline. All of these patients showed a fall in in circulating tumor DNA at 3 months. So at the 3rd cycle of therapy. So, showing good activity that could be measurable to potentially or monitored potentially in the blood. And finally, the safety profile was similar to what we talked about earlier in the ivonescimab trial, with VEGF-related toxicities seen in a proportion of patients, and about 2% of the squamous cell population, 4% of the squamous cell population, there was some degree of hemorrhage. But overall, the safety profile was pretty good for this combination. this treatment combination. So this is the first global data for PD-L1 and VEGF-A bispecific antibodies in non-small cell lung cancer, irrespective of histology. Good activity seen in non-squamous and squamous cells. Great activity also seen in PD-L1 less than 1%. PD-L1 greater than 50%, 100% response rate, and a manageable safety profile in both histologies with no new safety signals. So that is now being moved into the phase 3 Rosetta trial. So, let's look at this space. It's going to be interesting. What about anti-angiogenic TKIs and the immune checkpoint inhibitor combinations? Again, we've seen these to have activity in the non-squamous subset, and this is what was done in this trial. I'm going to call this called Benmel-Stobart. Is a humanized monoclonal antibody against PD-L1. It's demonstrated activity in extensive stage small cell and unresectable stage 3 non-small cell. And Lotimib is the first and only multi-targeted anti-angiogenic TKI that has shown significant overall survival benefit in the third-line setting of non-small cell lung cancer. So these were combined together to see what they would do in terms of clinical activity. This is the trial design, very similar to the previous designs you've seen, which is the Benmel-Stobart plus carboplatin and pemetrexed versus the tislelizumab design with Lotimib added on in the maintenance setting. The primary endpoint was progression-free survival assessed by independent research committee, and it showed an improvement in progression-free survival, and it's quite an impressive one, from 14 months in the Bel-Mel chemotherapy versus 8.3 months in the control arm. When we look at the secondary endpoints, you can see here, this is a look at the PD-L1 expression. Again, it's interesting that those with less than 1% seem to have done very, very well. But when we go up to the 65-year-olds, again, you can see it crosses unity there. So less benefit in the older population than in the younger population. In terms of the safety profile, the things that stand out are hypertension, which is 11.7%, and also hypokalemia, which is 8.1%. The other toxicities were pretty similar and would be what we would expect. So this is the first global data in a PD-L1 VEGF antibody bispecific antibody first-line non-small cell lung cancer plus chemotherapy, showing encouraging efficacy in terms of response rates. The response rate being seen throughout all of the PD-L1 groups, a manageable safety toxicity. So it's interesting data. But that was a Rosetta conclusions, apologies, but that's the same outcome for this trial. So let's go back and look at the 3 studies and think about things in the 3 studies that might be important, okay? So the issues that need to be addressed in all combined PD-1 and PD-L1 and VEGF pathway studies exemplified in the Harmony 6 study are very similar. If we look at the comparison of Harmony 6 versus the Rationale 307 trial, which was tislelizumab chemotherapy in the Chinese population, okay, and the Keynote 407 trials, both the global and the Chinese population, we can see that the median overall survivals in the trials in the Chinese population suggest that pembrolizumab may be equivalent to the Harmony trial. The 1-year survivals are very similar, and the 2-year overall survivals are interesting as well. So I think we have to do a bit of work to see if the data that we're seeing in the Chinese population will be reflected in the global population. When we look at the PD-L1 results for PD-L1 negative non-small cell lung cancer, we can see again the overall hazard ratio is 0.64, 0.73 with the tisla, pembrolizumab 0.5, and the pembrolizumab chemo for the global population 0.83. Interestingly, in these situations, there is a separation of the curves for the Harmony 6 trial, which does look very encouraging in that PD-L1 negative population. And then when we look at the different populations for Chinese versus and East Asians, you can see it in terms of the different types of different trials, PD-L1 less than 1%, and PDL greater than 50%, we can see that obviously there's a difference in the ethnicity in these studies. So again, we need to kind of confirm that the data applies to all populations. And then there's this issue that was brought out again in the Harmony 6, and we've seen it in the other studies, that the older population doesn't seem to get a benefit from this combined VEGF PD-1 or PD-L1 combination bispecific antibodies. So again, we have to see, because a lot of our patients are elderly, the study, the Harmony 6 study excluded patients over the age of 75 years. And so we have to think, is this going to be a benefit to the older population? So maybe that's going to be focused on a younger population to get the benefit. Maybe the older population is not going to get the same benefit from this approach. But still, I think the data are really encouraging. And maybe we're going to have an effective new way of approaching the care of our patients with both squamous and non-squamous non-small cell lung cancer. So the take-home messages overall, and this was the talk given by Julie Bramer, was ivonescimab plus carboplatin paclitaxel is effective for Chinese patients with advanced non-small cell lung cancer based on the interim overall survival. The results in VEGF, it does result in VEGF-related ANEs, and there is some uncertainty regarding patient selection. And applicability to the global, generally older squamous cell lung cancer population is unclear. But being an optimist, I think we have a new class of drug coming to the fore. So, I love this slide. This was Julie showed this. 20 years, what's old is new again 20 years later? Well, they got Devil Wears Prada, and then the Devil Wears Prada 2. And so I think, exciting data, and hopefully that will help to develop better care for our patients in the future. So what about antibody drug conjugates? This is a study presented by Kai-Kun Zhou, and it looks at sac-TMT, the TROP2 antibody drug conjugate. And you can see the payload here, 8 chemotherapy molecules attached to the TROP2 antibody. And so it's a good payload, and it looks very encouraging from previous studies. This is the data that was presented in EGFR TKI resistant, EGFR mutated non-small cell lung cancer at ESMO. And you can see again this really impressive improvement in outcome compared to chemotherapy. So establishing certainly in China a new standard of care for EGFR mutated non-small cell lung cancer relapse disease. So Optitrope Lung 05 looked at sac-TMT for pembrolizumab versus pembrolizumab alone, and in PD-L1 positive tumors. And these are the characteristics of the two arms. They're well balanced with no major difference. And you can see here in terms of the TPS score for PD-L1, again, well balanced between both arms. And this is the overall progression-free survival by independent review. And you can see here the progression-free survival has not been reached at 12 months for the combination arm versus what we see with pembrolizumab alone. When we see the benefit, again, we see that there's a benefit for all subgroups. In this case, the greater than 65-year-olds are getting the same benefit as those younger age. When we look at the PFS by histology, again, benefits are seen in both adenocarcinoma, or non-squamous non-small cell lung cancer, and squamous cell lung cancer. When we look at it by PD-L1 expression, again, the same holds true. And when we see a descriptive overall survival benefit, we're seeing a HR of 0.55, which is really quite remarkable if that holds true for Caucasian patients. So this is the adverse events of special interest, and you can see pretty much what we would expect from the sac-TMT coming through plus pembrolizumab. You can see any grade toxicity greater than grade 3 in particular. You can see this is the neutrophil count, the stomatitis, this anemia, ocular toxicity, etc. And then this is the pembrolizumab arm. So a bit more toxicity than with pembrolizumab alone, but certainly manageable. And so I think this slide really sums it up quite nicely, the difference between the sac-TMT and pembrolizumab. So this is looking at the intention to treat population. The PFS has not been reached. This is the control arm. You look at the TPS greater than 50%, again, this benefit, the TPS 1 to 49% of benefit, and then the overall response rate looking good. So one could argue that perhaps the 1 to 49 control should have been pembro plus chemotherapy, but certainly it's a very encouraging result. So there were the kind of highlights for me in the immunotherapy and ADCs in non-small cell lung cancer. And moving to small cell lung cancer, just a couple of things to go through. The first study is the combination of ivonescimab combined with liposomal irinotecan in second-line setting. This is called a victory study. Here's the study design. It was a single-arm phase 2 trial, and the primary endpoint was 6-month progression-free survival by RECIST, and this is the secondary endpoints were overall response rate, PFS, duration of response, and overall survival. And what we saw really was an excellent response rate for this combination, 61.7% overall response rate. The response rate, interestingly, was equivalent between both the patients who were platinum sensitive and platinum resistant. And I think this is really quite nice. This is the 6-month progression-free survival, 69.1%. And this is the overall survival, with the median survival not yet reached. So, again, encouraging data. So promising anti-tumor activity demonstrated in this setting, high response rate, median duration of response was 7.3 months, with second-line combination of PD-1, VEGF blockade, plus liposomal irinotecan. Consistent benefit across whether it was platinum sensitive or platinum resistant, the same response rate seen, and PFS as well, looking very nice, an acceptable safety profile. So, again, the VEGF story re-emerging, the resurrection of VEGF and treatment on small cell lung cancer. This is a short note on tarlatamab versus chemotherapy, second-line treatment for small cell lung cancer, the Delphi 304 trial, the second-line treatment trial versus chemotherapy. And you can see tarlatamab delayed CNS progression or death in patients with brain metastases. So this is obviously very encouraging for us in treating our patients. And then on top of that, if you look at patients who had or did not have brain metastases, so with brain metastases, red, without brain metastases, orange, you can see the survival curves are on top of each other. When you see patients without brain metastases, as you would expect, the light blue curve is in the control arm, does better than the patients who have brain metastases. So again, very encouraging data that this bispecific antibody is going to really add to the care of patients with small cell lung cancer. And then finally, I have to mention one of our own team. This is Suryan Arulatananda, and he was the first author and presenting author of this paper, which looked at a phase 1 study of 177 lutetium SSO110 with 68 gallium SSO120 companion imaging in patients with extensive stage small cell lung cancer, and then maintenance treatment with immune checkpoint inhibitors after chemotherapy. So this trial was run largely in Australia, and I think the preliminary data is kind of encouraging. So it's a movement into theranostics, radiopharmaceutical-based therapy in small cell lung cancer. Who thought that might happen? But there we are. I have to claim a little bit of work in this. Back in the day, I was the first person to actually do radio-labeled octreotide imaging. It's part of my thesis many years ago. So for those who are young here and are doing their PhDs at the moment and MDs, what you're doing now might actually happen to have benefit about 30 years later. So I always keep that as a good message, it might be relevant. And so this uses lutetium 117 linked to basically an octreotide analog, and the patients were imaged first and then treated subsequently with the DOTA-TATE agent. And you can see here, this is the as part of the workup, the patient had immunohistochemistry. You can see high expression of the somatostatin receptor 2 in the C picture here. And so what did the results show? Well, it was a dose finding study to find out what the dose in terms of megabecquerels would be in terms of becquerels would be in terms of being able to move forward in subsequent trials. And that's the outline of the inclusion exclusion criteria. The patients had to have a response to treatment. There was 3 dose levels tested, and the grade 3 dose level was associated with significant thrombocytopenia in 5 of 12 patients. So the DL, this is dose level 3, and that was defined as the maximum tolerated dose. And you can see a progression-free survival was for the whole population, which is shown here. And the patients who went on to maintenance had 3.7 months of progression-free survival and had an overall survival benefit, or overall survival of 8 months in the maintenance setting after commencing maintenance therapy with the radiolabeled treatment. And so the summary is that the addition of 177 lutetium SSO110 to maintenance ICI in extensive stage small cell lung cancer is feasible. Hematological toxicity, particularly thrombocytopenia, was the most common adverse event. And this study warrants further investigation in larger prospective studies with the RP2D dose of 4.5 GBQ. So I think this is, encouraging activity, and it's, it begins the movement into theranostics in small cell lung cancer. A nice thing to see. We have, good data in prostate cancer, good data emerging in other tumor types, obviously with the NETs, where lutetium labeled dotatate is a kind of standard treatment. So I think you might find the same happens in extensive stage small cell lung cancer for those that have high levels of expression of somatostatin receptor 2. So to finish off with small cell in my last slide, I think we can say that the PD-1 VEGF-A bispecific antibody therapy in combination with liposomal irinotecan in second-line setting is really promising. Activity is seen in the platinum-resistant population is equivalent to platinum-sensitive cases. Tarlatamab has demonstrated CNS activity, and the dawn of theranostics for the treatment of small cell lung cancer has arrived. So thank you very much.
Brilliant. Thanks, Ken. That was a perfectly timed presentation, finished right on time, and some really interesting data there. I'm sure we'll see lots of questions coming through in the chat for our Q&A at the end. But we'll move on now to the next presentation, which is from Dr. Ben Kong. So Ben is a medical oncologist at the Prince of Wales Hospital and a senior research fellow in the Sphere Cancer Clinical Academic Group at the University of New South Wales. Ben trained in New South Wales before completing a PhD in cancer immunology at the University of Sydney, evaluating strategies to combine immune checkpoint inhibitors with cellular therapies. His current research interests are in thoracic and head and neck cancers and brain metastases. Thanks, Ben.
Thanks, Maggie, for that kind introduction, and Ken, for a great talk. That was really interesting and entertaining. So tonight I'm going to be speaking about advances in targeted therapy for non-small cell lung cancer. And as always at ASCO, there is an overwhelming amount of information. So tonight I would certainly like to focus on a few key themes, and had to use all my energy to resist the temptation to speak about brain metastases as well, because there were some very interesting radiation themed abstracts. So apologies to the radiation oncologists out there. So in terms of systemic therapy, there were some key first-line driver mutated advanced non-small cell lung cancer abstracts presented, as well as data in adjuvant treatment with RET fusion lung cancer. So I've given a visual of some of the trials here, so you can remember some of the acronyms, which I always struggle with. So in the RET space, we had adjuvant selpercatinib in the Libretto 432 study, as well as first-line pralsetinib in advanced RET fusion non-small cell lung cancer. We did have some interesting data in the EGFR space, particularly looking at exon 20 insertions and unusual EGFR mutations. And on the right, just to remind you, there's Wukong, the Monkey King, as well as Chrysalis, to remind you of the amivantamab lazertinib study. Of course, there is always more data on the CROWN study and some practice affirming data to remind us of how important that is for our patients. I'll finish off the presentation today by going through some emerging data in KRAS as well. So, starting off with RET fusion non-small cell lung cancer, I'd like to start with the sort of key take-home messages. and those are number 1 in the plenary session, adjuvant selpercatinib in stage 1B to 3A non-small cell lung cancer in the Libretto 432 study, improved event-free survival with a very significant hazard ratio of 0.17. In the metastatic space, first-line pralsetinib was shown to be associated with an improved progression-free survival compared with standard of care, which in this case was chemotherapy plus or minus immunotherapy, with a median PFS of 18.7 months compared to the control arm of 9 months, and that's in the Excella RET study. Just taking a step back and thinking about RET biology, because this is a rare tumour, and of course we don't see this too often. RET fusions are 1 to 2% of all non-small cell lung cancers. And as you can see on the right-hand side in the diagram of here, I've just reminded us of some of the fusion partners that we may see with the RET gene, including KIF5B, NCI4, and we expect that in RET fusion positive disease, as with many other driver mutated phenotypes, we'll see frequently patients with brain metastases, with up to a quarter of patients presenting with brain metastases, or up to half of them developing brain metastases during the lifetime of their disease. Selpercatinib is approved for first-line treatment of the PBAC for metastatic disease in Australia. However, pralsetinib has accelerated FDA approval based on the overall response rate of 70% in the earlier phase ARROW study. And so this is what underpins some of the metastatic abstract data that I'll present today. So if we move to the sort of headline plenary session, this was the Libretto 432 study looking at the use of adjuvant selpercatinib in patients with stage 1B to 3A non-small cell lung cancer. And in this study, selpercatinib was compared against placebo. There were a total of 151 patients in this study who were randomized 1-to-1 to either arm, and they had to have had definitive surgery or radiotherapy plus adjuvant chemotherapy where appropriate, as determined by the investigator. And the endpoint in this study was investigator-assessed event-free survival. As you can see in the schema on the right, this treatment was completed for up to 3 years, in line with many adjuvant driver mutated studies, up to the point of disease recurrence, progression, or death. So these are the baseline characteristics of the patients in this study. You can see that there was a spread of patients across East Asia and North America, with a predominant East Asian population. Most of the patients had either a KIFB or CCDC6 RET fusion detected, and approximately half of the patients had PD-L1 positive disease, with a significant proportion having unknown PD-L1 status. Now you can see that although surgery or radiotherapy was allowed, the overwhelming majority of patients in this study did in fact have surgery at the time of study entry, and over 90% of them had systemic therapy, which was predominantly chemotherapy. However, there were a small number of patients, for reasons unbeknownst to myself, who did have some immunotherapy. This is the primary outcome of the study, event-free survival by blinded independent central review. And you can see there that there is a statistically significant measurable hazard ratio there underlining these results. So this is adjuvant selpercatinib in stage 1B to 3A non-small cell lung cancer. Perhaps not a type of presentation that we individually see very commonly, but this is encouraging data and parallels some of the data that has been presented in other types of driver mutated lung cancer. So if we think about the considerations for adjuvant treatment and compare this to, for example, the ADAURA study in EGFR mutated lung cancer or ALINA, in this RET study, over 90% of the patients have adjuvant chemotherapy, whereas in ADAURA, that was 60%, and in ALINA, those patients were actually randomized to either targeted therapy or chemotherapy. And that sort of may make sense if we think about the disease biology in EGFR and ALK fusion lung cancer. But nevertheless, this is a key difference with this study comparing to those other sorts of driver-mutated lung cancer. I mentioned earlier that CNS metastases are important in genomic lung cancer. And just to remind you, in the ADAURA study, the hazard ratio for development of CNS metastases was 0.24, with a similar effect in ALK fusion lung cancer. Although this specifically wasn't reported in the RET abstract we've spoken about today, I expect that there might be a similar effect. So this is something that we watch with much interest in future data presentations. So this leads to the question, should all of these patients with stage 2 or 3 lung cancer have adjuvant selpercatinib? And this comes back to the concept of what the treatment-related toxicity may be in some of these patients, bearing in mind that they may have this treatment for up to 3 years. And so to answer that question, we need to look at the disposition of some of these patients. 17% of the patients discontinued during this study. There was a dose interruption in 77% and a dose reduction in 55% due to transaminitis, diarrhea, dry mouth and cough. So obviously these translate into very important questions about what the duration of treatment may be, as well as important questions about cancer survivorship, which will of course be answered in real-world data. Now, if we change gears slightly and think about RET fusion-positive disease in the metastatic setting, the Accelerate Lung study was an open-label randomized phase 3 trial looking at pralsetinib in the first-line setting, keeping in mind the overall response rate of 70% in earlier phase trials. In this study, patients were randomized 1-to-1 to either pralsetinib or the investigator's choice of platinum-based chemotherapy. And there was, in fact, an optional opportunity to cross over upon progressive disease. In this study, approximately 34% of patients did cross over eventually. And although the primary endpoint was progression-free survival, there was a secondary endpoint of overall survival as well as clinical benefit and disease control rate. But this was a large phase 3 style study with planned enrollment of 226 patients. So in this study, importantly, as I said before, there was some patients who did discontinue pralsetinib, but by and large, there was a good participation rate with approximately 1/3 of patients crossing over upon progression. So thinking about the baseline characteristics of patients in this study, we can see that the male to female ratio was, perhaps slightly larger in the pralsetinib population compared to standard of care, but approximately 50% over each gender. In this study, the participants were 60% white, 20% Asian, and that's certainly something to consider when applying this treatment across different patient populations. And that's reflected in the regions covered in this study, which were predominantly in Europe. Interestingly, the smoking status in this study was 60% never smokers, but importantly, there was a significant proportion of patients who were either former or current smokers, and I'll come back to that point a little bit later, as well as 30% who had a history of CNS metastases. In this study, the control arm was standard of care, which meant a chemotherapy plus or minus the use of immunotherapy, which was in approximately 60% of patients. And this is the primary outcome of the study, showing that pralsetinib treatment reduced the risk of progression or death versus standard of care, with a median progression-free survival of 18.7 months compared with 9 months in the standard of care arm. All right. So as always, the devil is in the detail. And if we look at some of these patient subgroups, there are some clues as to how we may choose to apply this treatment in our own patient population. You can see immediately as you cast your eye down these subgroups that, of course, the hazard ratio crosses the line of significance in older patients. In Asian patients, perhaps there was a wider confidence interval, and certainly in those with CNS disease, which presumably includes symptomatic and asymptomatic CNS disease. Again, that line of significance wasn't as impressive as those without. So these are perhaps clues as to how we might apply this treatment in our own patient populations when it comes to the clinic. Now, this is an important slide which also speaks to implementation. In this study, the adverse events related to pralsetinib importantly include a proportion of patients, in fact 14.8%, who had deaths attributed to the adverse events, which was largely driven by infections and in particular pneumonia. So I think this is a key slide and consideration in some of our patients, bearing in mind that the standard of care here, chemotherapy plus pembrolizumab, is not without its own toxicities. Overall, in the study population, however, the AEs leading to withdrawal were 16.7% in the pralsetinib arm compared to standard of care. And so, in fact, what was reported at ASCO was also some data from a access program and post-marketing surveillance, which showed that with some changes to trial amendment and monitoring, that this adverse event was in fact all but eliminated. However, this is certainly an important piece of evidence in adverse effects for pralsetinib that should be considered when we are applying this to a real-world population. So how does this compare to selpercatinib, which is our RET fusion-directed treatment currently on the PFS, on the PBS? So this is the data from the selpercatinib study. And you can see that in these studies, although the control arms did have slightly different median PFS, pralsetinib was associated with a median PFS of 18.7 months, whereas selpercatinib, 24.8 months. And of course, this data needs to be interpreted in terms of the data maturity, as well as some of the adverse events. But, numerically, pralsetinib, although it's not exactly the same as selpercatinib, we're still talking about the same sort of ballpark. And again, some of that will be in the detail of the patients included in the study. Now, I want to talk a bit about bypass mutations, which are very common in RET mutated lung cancer. Approximately a quarter of patients will have a solvent front domain, which is an on-target acquired resistance. However, the overwhelming majority of patients who acquire resistance in RET fusion positive disease do have bypass mutations, and this is data showing the mechanism of mutations in both pralsetinib and selpercatinib treated patients. So you can see MET amplification as well as KRAS mutations are very frequent as mechanisms of resistance. If we compare pralsetinib to selpercatinib, the differences in adverse events lie largely in a slightly increased transaminitis in selpercatinib and hypertension. However, this is offset against some of the infection risk that was seen in the pralsetinib phase 3 trial. So how do we apply this evidence to practice, and how might this look in our patients? There are a few points that I need to make, which is that in the Accelerate trials, up to 30% of patients were former smokers, and we also saw the data in adjuvant treatment in early stage disease. So in the Australian setting, this leads me to the mantra that we need to test, test and test, and think of this even in early stage disease, particularly thinking that knowing that a RET fusion positive disease may be sometimes even better detected on RNA sequencing platform. So this is something to consider at the point of diagnosis. The crossover design of the first-line pralsetinib study, although this doesn't sort of show us the overall survival difference, the very impressive hazard ratio and improved PFS would lead us to think that this is going to have a significant impact in our patients as this data matures. But some of the caveats we need to think about are the infection risk with pralsetinib. as well as the lack of fusion partners that were documented in this study, and to think about what that might mean for on-target and off-target resistance in the future. Lastly, I guess something for a future investigator-initiated question or de-escalation question: in adjuvant selpercatinib, is chemotherapy needed in the same way as it was used in this study, or can we look at this in a sort of de-escalated setting as in other driver-mutated lung cancer? Something for the future to think about. Now, I'm just going to move on to EGFR now, and to start off again with some of the take-home messages. The interesting abstracts were, in particular, the phase 3 study of first-line sunvosertinib in EGFR exon 20 inserted non-small cell lung cancer, the Wukong 28 study, as well as presentation of data from the Chrysalis 2 study of amivantamab plus lazertinib in unusual exon 20 mutations. There were certainly other interesting abstracts in EGFR lung cancer, which we don't have time to go through today, but these are the 2 abstracts which I'll focus on. So just again, winding back, EGFR 101, this is approximately 17% of mutations in non-small cell lung cancer in Australia, and EGFR exon 20 insertions are probably less than 1%. So again, some of the statements I made about RET fusion lung cancer and testing certainly apply here. We know that EGFR exon 20 mutated lung cancer has a low response rate to first and second generation inhibitors, and so this is the rationale for the use of sunvosertinib, which is FDA approved for non-small cell lung cancer after chemotherapy, and also approved in the same setting as well as in the first line setting in China. However, this is not currently TGA approved. On the right-hand side here, I've shown you what the sort of spectrum of exon 20 insertion mutations may look like, including so-called PAC mutations and near loop and far loop mutations. There's been a sort of quite a history of targeted therapies for exon 20 insertion, so it's taken us some point to get to this point where we in fact do have a therapy that's close to the market, and we're all very disappointed that mobocertinib came close, but there was a sort of global withdrawal of that treatment. So this is really exciting to see some new therapies in this space, where we currently have some therapies PBAC approved, such as amivantamab and chemotherapy, but this is the first phase 3 targeted study. These are the baseline characteristics of these patients. These fit more of our typical Asian female non-smoking EGFR mutant population, and the exon 20 insertion subtypes I've shown here below. It was predominantly 2 subtypes, but there were many other subtypes of EGFR exon 20 insertions in keeping with what we know about the heterogeneity of this disease. This is the blinded, independent, assessed tumour response. If we look at these headline results, we can see that sunvosertinib has a confirmed overall response rate of 58.9%, compared with the chemotherapy arm, which has a confirmed overall response rate of 31%. If we move that into the primary outcome of the study, the blinded assessment of PFS, you can see that sunvosertinib is associated with a median progression-free survival of 10.3 months compared to chemotherapy at 7.5 months. So although this is only a sort of several month difference in what we are looking at in this case, that needs to be taken into context in both the subgroups that we are treating as well as the potential adverse effects. And again, the devil is in the detail here, so you can see in the subgroups that perhaps in the non-Asian populations, in patients with brain metastases, and in those with far loop mutations, that effect is perhaps less marked, bearing in mind that some of those groups are fairly small, like the brain metastases groups. Nevertheless, these are considerations when we're applying this data to our patients. And fortunately, the adverse event profile of sunvosertinib was fairly well tolerated. Although we did have many patients with many of those sort of typical TKI expected adverse events, such as diarrhea, rash, paronychia, and CPK increases. In fact, there were relatively low numbers that had sort of grade 3 or above. And in fact, in this study, there were no fatal outcomes and sort of single-digit patients who had adverse events that led to treatment discontinuation. And I can say in the Wukong 1B earlier phase study, the incidence of pneumonitis was also fairly low, I believe below 2%. So this is a very well-tolerated treatment. Just to round off the EGFR story, and this is data which has been sort of reported before in bulk format, but in the Chrysalis-2 study, the data regarding atypical EGFR mutated non-small cell lung cancer, such as the G719X, S768X, and L861X mutations were reported. And this showed that in these mutations, we have an overall response rate of 57%. And I think this is key in the Australian setting, particularly with regarding to the current PBAC wording for amivantamab plus chemotherapy, which is limited to exon 20 disease. So if we think about how we might apply this evidence to practice, we've seen in the EGFR space the data for sunvosertinib in the first line. We've seen the median PFS reported for unusual EGFR mutations for amivantamab plus lazertinib, which is not available in Australia, with a median PFS of 11.2 months, but an important consideration for those with unusual EGFR mutations. And then contrast this with the median PFS that we know holds up for amivantamab plus chemotherapy in the exon 20 space. So clearly there are two potential options for patients with exon 20 disease. I should note that there are many phase 3 studies coming through in this space, so we await with much excitement zipalertinib and furmonertinib in the future. Now, I'm just going to briefly touch on this because this is hopefully data that we've all seen, but this is just a reminder of ALK fusion lung cancer and the sort of amazing durable response that we're continuing to see in lorlatinib. And this was the 7-year data reported from the CROWN study, showing the data for a median duration of follow-up at 83 months. And Tony Mock nicely presented this data and noted that over the past 2 years, fortunately, not too much has happened and only 7 patients had new PFS events, which is remarkable in itself, and affirmation of this as a sort of potential first-line treatment for ALK patients, which holds across the brain metastases space as well. So this is certainly practice-affirming data and really nice to see for these patients. Now, we did also have some Australian investigators on the ALCO-1 study, and this is looking at nedalalkib, the phase 2 data, showing activity in single and compound mutant activity. And importantly, many of these patients actually were lorlatinib experienced, and although this response rate is, sort of disappointingly lower than one would want for your patients, this is certainly an exciting option that's coming through for some patients. And for those who are TKI naive, the overall response rate was 86% in the ALCO-1 study. So some important new directions in ALK. I'm just going to finish off my presentation today with a taster about what might be in the future for lung cancer and talk a little bit about KRAS mutant lung cancer. We've seen that in the KRAS G12C space, sotorasib, which had a phase 2 overall response rate of 32%, was somewhat disappointing in phase 3 trials when compared to docetaxel. At ASCO this year, we saw some new KRAS G12C and G12D inhibitors. So in the G12C space, in the first line, we saw divarasib and elsorasib, which are showing a much higher overall response rate in themselves, 73% and 81%. And the TNS1611 compound in G12D mutated non-small cell lung cancer with an overall response rate of 44%. The reason I bring this up is that KRAS, being an intracellular target, was always thought of as undruggable. And who would have thought that we would see some inspiration from pancreas cancer for our non-small cell lung cancer patients? And I just thought I'd show this even though it's not non-small cell lung cancer. This is a pan-RAS ON inhibitor in the G12 RAS population in pancreas cancer. And you can see a very impressive and visible overall survival difference. So this begs the question of what this might look like in lung cancer. There is hope out there. Should we be chasing the KRAS alphabet, or is this multi-kinase inhibition the answer? So we hope to see some exciting data in lung cancer in this space too. So what am I going to do tomorrow when I go back to the clinic? I think this strengthens my resolve to continue to look for driver mutations in all different settings and not just seek out those patients with textbook phenotypes. We've seen that selpercatinib is showing some very impressive data, but of course, to implement this in the real world, we need detection of these patients in the first place and management of adverse effects. We hope that sunvosertinib will be reimbursed and provide additional options for our patients with EGFR exon 20 insertion. And unfortunately, lazertinib is not available in Australia in that setting. I'll continue to marvel at the long-term ALK responders, and there's more data coming which will further improve their outcomes. And of course, we know that all of these driver mutations are difficult to manage when we start to think about resistance, understanding responders and non-responders, where phase 3 data does not answer this question. So I will certainly be entering all my patient data into Aurora so we can ask some of these questions to implement these findings in the Australian setting.
Thanks so much, Ben. Great talk. And I love that you snuck the Crown data in there, because that's really aspirational data for all of us treating lung cancer. So great to see still holding up so well at 7 years. All right, so we're moving on now to our last speaker, who probably needs little introduction to most of you, but Associate Professor Malinda Itchins is a thoracic medical oncologist at Royal North Shore Hospital, Chris O'Brien Lifehouse, and the University of Sydney. She's a board director with COSA and deputy chair of the TOGA Scientific Committee. She is a passionate trialist, researcher, and advocate for improving care for all people affected by lung cancer. Thanks, Mel.
Thank you, Maggie, and thank you, TOGA, for the invitation back to go through the poster picks, which was a new addition to last year's post-ASCO mashup. So I thought I'd start with, I'm going to sneak in Herbert's poster on sevabertinib, and I love the poster selfies. And what I love about this one is if you look closely, you can see the Chris Hoffman there, who's actually the zongertinib global head. So just a little tongue-in-cheek one there as he's presenting the HER2 data. So progressing on. Acceptance. Oh, there we go. There are my disclosures. And a couple of disclaimers. I didn't go. I put on a face mask and I clicked for hours looking through the posters, and I did a bit of well, thankfully, I had a colleague there, as Ken has said, Serene, who kindly I woke up to in the morning summaries of everything I need to know. So I feel like I did the lazy person's guide to ASCO, which was very appreciated. And then I did a bit of watching of the people, the who's who that we aspire to be on Twitter. And then lo and behold, just after ASCO, I got a text from Nargis wearing the mask I gave her when she came out to Australia. So I was a bit chuffed about that, and hopefully her skin's looking very good. So a couple of acknowledgements. I think we've already heard it, haven't we? So Tom John, just with those that were involved in the oral presentations, was involved in the Wukong 28 sunvosertinib abstract we've heard, and a NEDGM co-author. Ben was on several abstracts, of course, Crown, including their Annals of Oncology, updated survival, Crescendo, the divarasib 170, Rosetta that Ken presented, and D3S001. Serene, as we heard, was the first presenting author for this Lisato 01, as well as was on the Brain Mets Delphi 304. And I was grateful to be on the neladalkib ALCOVE-1 ALK inhibitor abstract, and there's Serene there in his glory. Poster picks, methodology of the systematic poster pick review. Did the title interest me? No. Well, that went through to the keeper. Is the content relevant to TOGA studies? Do they inform, I guess, our ongoing gaps identified? Does it look like they're influential or informing to our practice? It doesn't fit into this 15-minute time slot. So 278 lung cancer posters. I shortlisted 26 and presenting on 15, and these are my sons, and I guess if you're going to eat the strawberry, it's getting presented. So interesting one, starting from screening, which is now obviously live for us in Australia, and we've all wondered, well, what's going to be our experience with small cell lung cancer in this population? So this is a poster looking at the impact of screening in small cell lung cancer, which was a retrospective review of the Indiana healthcare system between 2018 and 2024. Now, I guess a lot of us have heard in the US, you know, how their screening going. I mean, I think it's not great. It's maybe sort of 5 to 14% around the traps. And I thought, well, are Indiana big sort of screeners? And I couldn't see that they are. But this was quite compelling data. So they looked at everybody screened. And they were able to look at the small cells, that came through the centre and whether they were screened or not screened. They took a look at their demographics and they saw that if you were screened, you were usually fitter, you had a family history of lung cancer, and you were a little fitter as well with regards to not having comorbidities like heart failure. So what they were able to find is you were significantly more likely to pick up a limited stage small cell lung cancer, bottom left. So actually 60% of the screen detected small cells were limited compared to 28% of the non. And actually 23% of all of their small cell lung cancers were from the screening program. You can then see there in the middle that with time, actually they're picking up more screen detected limited or small cells altogether. And then to the right, you know, as we would hope and expect, you can see that survival is absolutely improved if you pick up the small cell on the screening program. Something that was interesting is if you're a screen detected, though, and I can't see it with my current slide is getting cut off, but actually you took substantially longer, several weeks longer to get your biopsy compared to if you've come through the door via the usually symptomatic channels. So I think that's interesting. And I guess just remembering that those being screened couldn't be a small cell based on the population we're bringing in. So then moving on to young people with lung cancer. So this was from Penn Medical Centre. True Agarwal is the senior author, and it's looking at the experience of young people with lung cancer. So they utilise the Flatiron Health data set, which is massive. You can see there top left, a huge curated US-based database in collaboration with Foundation Medicine. And what they did is they teased down those whom had genomic profiling and then looked at those who were young, classified as less than 50 versus older, and tried to look at their outcomes. Because it was acknowledged, as we know, that younger people with lung cancer have biologically distinct disease in general. Generally, less smoking, more oncogene driven, and unfortunately more inherently metastatic. So this was to further define, I guess, the US population data of what to expect in this population. So it's a retrospective cohort study spanning over 12 years, as you can see there, trying to understand treatment outcomes, stratified by age, smoking, comorbidities, and molecular status. So interestingly, 3/4 were treated in community centres, 1/4 in academic centres. Only 5% of this US data set were Asian, and most 70% were metastatic versus 49%, which had earlier stage disease. So it was found that younger people had more adenocarcinomas. The PD-L1 distribution was similar, and their oncogenes were a little bit more abundant, but not greatly so, 48%. I thought it was really intriguing, and I couldn't include everything, but in those 18 to 30, 51% didn't have an oncogene, and that wouldn't be something I'd expect or quote, and I think more about that population being more like 90% above. But then when they looked, if you are young, less than 50, you're 9% more likely to have an ALK rearrangement, twice as likely to have an EGFR mutation, 5 times more likely to have a ROS1 in this population. You're more likely to have more lines of treatment if you're young for a longer duration. However, interestingly, time on treatment was short. So in the ALK group, 9 months, we just saw the CROWN data, and then ROS1, 6 months. So that triggered to me a little bit what's happening out there in the community. However, young people lived twice as long, but we've seen their oncogene enriched, and it was 2 years. So interesting data, perhaps a little different to our Australian experience, and to Ben's point, which we're increasingly defining through Aurora. So the next one was interesting. So this is an abstract, impact of adjuvant immunotherapy after a PCR in neoadjuvant chemo-IO in resected lung cancer. So this was looking at the advantage of perioperative immunotherapy, which is a standard of care in the US. In Australia, as we're aware, via Medicare, we're unable to access checkpoints post-neoadjuvant. So the aim was to examine PCR versus non-PCR and what happens. So this called upon another large US database. You can see where I'm going with this. So National Cancer Database after 2018, big numbers, 1,400, a third of the people had a PCR. And then you can see there some curves that are sitting pretty on top of each other, or even the perioperative immunotherapy in the PCR group showing a shorter survival. So interesting, including in non-PCR, actually there wasn't an advantage in this retrospective review of more immunotherapy. And I think that's a group where we've been thinking the sandwich approach may be beneficial. So my take home to this abstract is refer to the TOGA trial ETOP adopt, which is trying to answer this question, randomizing people to postoperative immunotherapy versus surveillance, with a particular focus on those that do not have a PCR as a primary outcome. So then moving on to the journey of what we're doing in the early lung cancer patients. This was the same group who then looked at, in the same database, survival outcomes between those that have purely neoadjuvant chemoimmunotherapy or purely adjuvant chemo and immunotherapy. So no sandwich approach. So and again, same time frame. It didn't say the exact number, but if you look at the small print of this Sankey plot, it's over 2,000 patients. Now, this colourful Sankey plot took me a little bit of time to get my head around, but basically what it's showing, for example, is the neoadjuvant to the far left and the adjuvant treated, and then it's the clinical staging at diagnosis versus what then happens at the surgery. So why this is interesting? Well, the neoadjuvants are going up a bit more, aren't they? So that actually is indicating to us that they're being downstaged at their surgical resection, whereas the adjuvants have got a little bit of a sway there down, which is showing actually at surgery there was a propensity, not always, of them being upstaged at surgery. So what was found in this particular poster was in this large group, certainly neoadjuvant treatment, had an impressive overall survival advantage, has a ratio of 0.7, statistically significant. If you had N2 positive disease, the hazard ratio is more impressive, 0.62. So I think that increasingly we need to be scrutinising more in our MDTs, neoadjuvant. That's when we can help, obviously, in the right selected person. So then moving on to a busy slide, but an important one, which is from the Dana-Farber group, which is looking at what do we do post-Pacific, which is a headache for us all. So chemo, radiation, and then durvalumab, and what happens in those people and how do we help them when they relapse, because that's been a difficult population, largely precluded from clinical trials. So we haven't defined what is best to do. Most of us have been a little hamstrung and give chemotherapy. And what we're doing is actually quite heterogeneous. So this was a global retrospective multi-center cohort study. They did a lot of propensity matching to mitigate the confounders of the types of treatments you got at relapse. I would say something I couldn't find on the poster was median time to relapse, as obviously that really influences what we're doing perhaps systemically. Big study, 319 people. The takeaway was actually an immunotherapy approach at recurrence significantly improved the outcomes regardless of PD-L1 compared to chemotherapy. And a lot of this group also had it with an anti-angiogenic. So bottom left, in brief, shows the different treatments that were adopted and also how people relapsed. So blue is loco-regional, and a lot of people with loco-regional still went on to have a systemic approach. Some of them there, 61, had local ablative treatment alone. And the type of approach she had. So green is brain mets. So we can see there those that had brain mets, and we know a third of people post-specific, relapse in the brain. I keep scanning the brain. Actually, they often had local ablative therapy and continued on durvalumab. I think that that's fair. There are a group who went on to have targeted therapy. Good idea if we're in our oncogene lane. But it is heterogeneous. Bottom right shows looking at the two groups of interest, chemo plus or minus angiogenic versus immunotherapy plus or minus chemo. Hazard ratio for PFS 0.46, overall survival 0.31. So that's a little bit interesting. And then just teasing it out a little bit more. So actually good objective response rates, 40% if you had immunotherapy, and we'd probably give it with chemo depending on the I guess the pattern of recurrence. And I guess if we look then down at the bottom, particularly further looking at PFS and OS for those two groups, as I've mentioned, very positive. So I think in this group now, we have the opportunity with the broad listing of nivolumab to look at re-challenging with immunotherapy and chemo. Of course, there's going to be bias. These are retrospective cohort studies. So they're probably fitter if they got chemo and immunotherapy, et cetera, et cetera. But I'd be thinking about that. And the next unmet need question, I guess, and a TOGA opportunity is a 9LA type approach in this population. So moving right along, then we have some Chinese data, which is interesting. Looking at a group I think we all are increasingly grappling with, which are those with advanced disease. I guess we'd call them wild type, who have immunotherapy and then who may have local ablation if they have oligoresidual disease. So this was updated data from the booster trial. So this was a randomized trial, phase 2, randomized 2-to-1 for oligoresidual disease post-immunotherapy. So this was disease in 3 or less organs and less than 5 metastases, and it was defined as when response was first documented, you became eligible. So in this one, however, it wasn't conventional radiotherapy. You were randomized to either thermal ablation or cryoablation. Primary outcome, progression-free survival. Secondary, overall survival, obviously safety, and then some immunogenic response markers, mostly blood-based sort of immune cell subset analysis, which wasn't presented on the poster. So actually this showed quite compellingly that local consolidative ablation conferred durable benefit with an edge towards cryoablation. Now, I have not been in a centre that's using cryoablation. It is becoming increasingly topical, and I think this is very interesting. I guess in the interest of time, we can look down at the 2 Kaplan-Meier plots there that show with ablation more than a doubling of progression-free survival, and then a little bit more information showing perhaps in small numbers an edge to cryoablation versus thermoablation, which is a little bit interesting. So I think, to be honest, in this group, it's really reasonable to look at consolidation, which I think we're increasingly doing and obviously trying to recruit to studies that do this to generate more data. Same Chinese group, overachieving, then took a look at the ablation in oligoresidual disease and its impact on survival in EGFR mutant. So we saw the North Star study, I think last year at ESMO, and again, we're increasingly adopting this into our practice. So this was real world data looking at local consolidation in the residual disease in the same defined oligoresidual as the previous study. The timing again was at least 3 months after starting therapy. I say that because we're working out what the sweet spot is for this type of ablative treatment. I think this was a retrospective study, but it wasn't actually specifically detailed on the poster, but basically it certainly showed survival was improved, recurrence was altered, resistance was altered, and the idea is, of course, eradicating those residual persister cells. So in super brief, I mean, it's a big study, of course, China problems. So hundreds of people, and you can see there the ablation group actually pretty impressive improvement in PFS, going from 17 months to 31 months. I mean, this is retrospective data, but, you know, drugs get approved certainly based on that Kaplan-Meier, let's be honest. And then when you go down to the bottom, small print, but I guess just to highlight that it was highly unlikely if you had the ablative therapy that you recurred in the sites of ablation. You also more likely recurred in less sites of disease. So, and then moving over to the plot of resistance profiling, I guess what we could highlight in these small numbers is that, and sorry that our chat is going crazy here, it keeps going over my slides, stop talking people. So what we could see is actually you didn't really see a lot of MAP kinase and off-target acquired resistance. Actually, you saw less small cell transformation, how interesting, and you didn't see any EGFR acquired mutation. So I like this type of scientific rigor. So moving on then to another group of overachievers being the Japanese with their very impressive also I guess, platform for research, LC Scrum. And this is the LC Scrum Tri study. So this actually looked at resequencing people who had a negative molecular profile at diagnosis and trying to understand the utility of then finding an oncogene. And what did that mean? So trying to look at those that were false negative. And they did this at the time point of treatment resistance. There was a little bit that wasn't defined, but basically this is a big consortium that works through the lead site of National Cancer Center in Japan. Patients were recruited between 2020 and 2025. Over 2,000 were enrolled. 840 were eligible based on having NGS. They had either tissue or liquid. They're lucky over there. And the panels were the Oncomine Precision Assay or Guardant 360. So what they found actually was 21% of people actually had an identifiable actionable genomic alteration at retesting. And that was more in adenocarcinomas and non-smokers and those that had prior early stage. The prior early stage hooked me because you couldn't work out if they had proper sequencing at early stage, only that it's Japan. I mean, they're doing things quite state of the art. But I wondered whether in that 21%, if some of those coming through had more PCR-based testing potentially, but I don't know that for certain. So in the middle there, you can see the genomic alterations that were identified, and they're our garden variety EGFRs, a couple of fusions, our KRASs, our HER2s. So they're the ones we want to know about. So survival was doubled then in those that were identified to have an actionable alteration and then go on to a targeted therapy. So that's the take home of that one. I think that, as Ben said, we need to always be testing. And I really do think about the shortcomings of our panels, particularly at treatment resistance, and always a good idea to have a look again. So our next one is updated data on olomorasib with pembrolizumab, and Brian Chan did a bloody good job at being the first author on this poster. So kudos to Brian. So this was looking at updated data in the population of PD-L1 less than 50% and whether we can chemo spare in this group now that we've got some good looking KRAS G12C inhibitors on the block. So it's looking at olomorasib and pembro, which has already had FDA breakthrough designation for the high PD-L1 population. So it's now looking at the others with updated 20-month follow-up. So overall survival, also PFS maturity is still premature, good problem to be having. But there were certainly durable responses seen, which you can see there in that swimmer plot in very small print, including in the light shade of salmon, those that are non-PD-L1 expressing. And they are obviously an important group to us. So they were having durable benefits as well. I couldn't see what the olomorasib objective response is in monotherapy in treatment naive because I don't think it exists. It's pretty good in pre-treated, maybe 40 or 50%. But down bottom left, you can see good objective response rates, so 60, 70%, which is great for KRAS and needed and durable. So I haven't used this drug myself. I've used some of the others. I think that when you can see here those that if they needed to discontinue, it was generally for transaminitis and some diarrhea. So, but it's increasingly safe. We're seeing through all the plethora of trials coming through, giving a checkpoint with our next generation KRAS G12C inhibitors. So moving on to this one briefly, I think, but this is another one of those massive genomic consortium in the US, the AACR Genie project, that basically looked at our old friends STK11 and KEAP1 via another iteration, and in those that are KRAS mutant, because we have for a while now been speculating and seeing data to suggest that perhaps immunotherapy isn't as effective in this population. So they tried to do a good job at understanding whether these sort of immune, I guess, cold phenotypic cancers are bad prognostically or predictive, in short. So what this poster didn't do was tease down the PD-L1s and tease down the different KRAS alphabet, but it tried to, I guess, control, for confounders and look at sort of landmark time points of survival based on those who have immunotherapy or chemotherapy, those that were wild type or altered. To cut a long story short, at this time of the night, in this group, it was negative prognostically, but with the fancy statistics I have not done justice to, it was not predictive for immunotherapy benefit in that particular population. The hypothesis did not hold. I'm getting the 5-minute mark. So SOHO 1, cevabertinib, SOHO 02, the first line phase 3 is still recruiting in a centre near you. This was the treatment naive data, both looking at 2 cohorts, D that had some chemo prior, or F that were completely treatment naive. This was the first time I had seen the treatment naive mature progression-free survival, and I think it really stacks up with zongertinib. If you exclude the squames, because this study did allow squames, which is lovely and needed, actually progression-free survival was 16.4 months, and that's in those also with YVMA mutations. There's some suggestion in that group, which is about half of HER2 mutants, may also confer more benefit. Diarrhea does look to be a problem. However, only 3% stopped. No interstitial lung disease. We love that. Half needed dose reduction, however. So let's watch this space, but I think this drug is here to stay. And so I'm coming towards the end, and I will stop very shortly, but this is an important one too. So MET exon 14 skip mutations, we're routinely testing now, about 5% of our lung cancers. Proper sequencing trials haven't been done, rare cancer problems. Should we give immunotherapy up front, or should we give tepotinib TKI? Most of us are giving tepotinib. Tablets are nice. The tolerability is challenging. So this is looking at long-term data at what happened for those treated first line, and what it showed us basically from the Concert AI Oncology data set from the US is that, interestingly, so objective response rates are good in both, a bit better in the TKI group, 77%, and then when you look at the overall survival, let's just flip to that. We can see actually it looks pretty compelling for the immunotherapy first line. So both progression-free survival and the overall survival on the Kaplan-Meiers there are actually better. And it looks regardless of PD-L1, but perhaps more compelling in the high PD-L1 population. So I put this up as I think for durability, I'm a bit interested in immunotherapy frontline. What this poster did not tease out was smoking status in greater detail, but I think we can talk about this in the discussion. So I might end it there. Larotrectinib is on PBS. Updated data in the 32 patients is still standard of care. And then this one is far too dense. Maggie is telling me to stop. So that one is us ending. But I would say the microenvironment in oncogene-driven lung cancer is probably our next key to understanding drug resistance and how we do better. Thank you.
Thanks, Mel. So good. So much information and so clearly presented. So thank you for that. For those online, keep the questions coming in through your live Q&A, right-hand side of your screen. And we will just start off with a few questions while those keep coming through. So Ken, you made the great point that the older population don't seem to get the same benefit as younger patients from the addition of VEGF. Has there been any talk about whether this is just age, or is age a marker of other comorbidities or something that might actually help us guide patient selection for this group or for this treatment?
So I'm going to be very brief. We don't know why.
Yeah. Okay.
Simply, it's just that it's a question that's being asked all the time, and we don't know. But interestingly, in the Chinese studies, they commonly exclude the patients over 75 in these trials. So that's kind of an interesting insight into how they feel about things as well.
Yeah. And just to follow up, this is a question from the audience. Can you give us any more information about who was excluded from, say, the Harmony 6 study in terms of could you have had PEs? Could you be on anticoagulation? And are there patients that even with that data, you still wouldn't feel comfortable using a VEGF-directed agent for?
Yeah, I think the standard exclusion criteria, the big one I think was if a tumor was invading a blood vessel. Obviously invading a blood vessel, that was a big exclusion criterion. The other criteria were a bit more loose, and I think it's something that I'd have to come back to for the absolute details of that. But certainly, what impressed me was actually some of the risk factors that we would have associated with high risk of bleeding, such as encasement of blood vessels, cavities, that those patients were included, and even though there was some hemorrhage, that rarely resulted in death, and the patients seemed to tolerate it pretty well. So I think even going back to the original bevacizumab data, we knew that there were good responses with squamous cell, but it just was excluded because of the risk of bleeding. And so I think this is just validating that, and probably a bit less risk than with bevacizumab.
Right. And we do have one more question for you, and then I'll leave you alone and move on to Ben.
Fine. Yeah.
So you alluded to the different kind of mechanism of action of pumitamig.
Yeah.
So I guess early days, but is your feeling that with that kind of extra, receptor degradation, do you think it's going to be more active than a drug like ivonescimab?
I think the issue is that we don't have the same data for ivonescimab. It wouldn't surprise me if exactly the same thing happens with ivonescimab as happens with pumitamig. There's this idea that the receptors on the white blood cells and the ligand is on the cancer cells. In fact, actually, the receptor is on the cancer cells as well. The ligand is also on the on the immune cells. I have just a personal hypothesis about this. The core to resistance in all cancers are stem cells. And interestingly, this intracrine system, this VEGF-driven intracrine system, is actually more pronounced in activity in stem cells than it is in other cancer cells. So I have a feeling, this is a personal view, and it's something I've suggested to the company to explore, is that bringing the VEGF antibody inside the cell on the link to pumitamig, even with VEGF-A attached, it may come off, that we may be seeing some sort of interaction with that intracrine pathway. And if that was the case, you might find there's more killing of stem cells, and hence that would ultimately lead to prolonged survival. So it's just a kind of an idea, but I think it's that those things are going to be explored more and more as we move forward, because we can do single cell imaging now and single cell quantification, which I think Mal hinted at about the last presentation. We're going to really begin to understand the biology of these things much more intimately. So this is really a fascinating time to be looking at these.
Great, thank you. All right, one for you now, Ben, and you are on mute, so I'll get you to come off mute to answer this. So this question is around the libretto data. And we did see that, amazing separation of the curves. But when you looked at the forest plot, and I think, some more data that was presented in the paper, it was really driven purely by the 3As, and the event rate in the placebo arm in the 1Bs and 2As was incredibly low at 2 years, compared to similar data that we had seen, in Adora and Alina. Do you have any comments on that? Do you think it's a quirk of a smallish study, or do you think it's real, and would it influence your use of the drug in those patients?
Yeah, no, that's a great question. And when I was looking through this data, I was certainly thinking of some of the data that you see across other sorts of adjuvant studies and the effect size, in Adora, where, some people certainly argue against using it for the really sort of early stage sort of patients. I mean, obviously the numbers in this study, we have to interpret with that in mind. I'd certainly, in a sort of applying this to a real population, exercise caution in that group. But I suppose what would be the clincher for me is when we see, assuming it's coming through the sort of CNS data, because, this being an adjuvant study, of course, we're going to see that effect size, but we also want to make sure that there are patients who are not sort of slipping through perhaps with, lower staging, but who might ultimately still be at risk of progression. So that's a sort of caveat I'd offer for that patient group. But agree with your sentiments about the statistics and sort of interpreting that carefully and using that in that sort of patient population. Certainly in the stage 3As, I'd expect that's going to sort of be more of a effect size there.
Yeah. Good. Okay. Well, that's all the questions that we had come through on the chat, and we're a few minutes ahead of time, but I think unless the panelists had any questions they wanted to ask each other.
So I just want to come back to the question that was mentioned asked about the exclusion criteria. I just want to give the specific list that I've just actually opened it up.
Oh, great.
While so basically bleeding and vascular risks. So tumors that significantly invade major blood vessels, I mentioned, history of significant hemoptysis, severe bleeding tendencies, coagulopathy, or active gastrointestinal perforation history. So, and all of those things make perfect sense in terms of what you would exclude, the patients you would exclude from this treatment. So
they could be on therapeutic anticoagulation.
It seems like that. I can't see anything saying they shouldn't be. But again, I'd have to look back. I'd have to go through the paper in detail for the published papers in detail to check that out. But they're both published now. The PFS paper initially was published last year, and obviously the overall survival has been published as well. So I think it's Lancet New England Journal, so they're available.
Yeah, great. All right. Well, a huge thank you to our three speakers tonight. We all know these talks take a while to prepare, and it's a bit nerve-wracking getting up in here in this forum. So thank you so much for all the time and effort you've put in. They were fantastic talks across the board. And thank you to everybody that joined us online. We'd love your feedback. Obviously, your feedback helps make these events even better. So if you could scan the QR code there, and there's just a very short survey about how you found tonight's webinar. I'll just leave that up there for a second so you can all scan. And I just want to say thank you again to our sponsor for tonight, who was Pfizer. And a reminder that the TOGA annual scientific meeting is upcoming on the 16th to 17th of July this year in Melbourne. And we'd encourage everybody to sign up and come along. It's always a great event.
Okay, I'd like to say good job, Maggie, and thank you very much to the whole team in TOGA for organising this webinar. Thank you.
Yeah, absolutely. All right. Good night, everyone.